Thank you so much. So I want us to start. So we'll be doing a pathology 2. Basically, we're looking at the systems and the various diseases and conditions that are found in those systems. So as you would expect, it's going to be quite it's a long one because as good as like anatomy 2. Basically, we are looking at all the systems. And today, we want to start with the cardiovascular system. And as we know, the cardiovascular system basically has to do with the cardio, which refers to the heart, and the vascular. Vascular is the vessels. Of course, now in the vessels, you'll be talking about the arteries, the veins, capillaries, all that, talking about the vascular, looking at all those systems and conditions that can in those particular systems. Yeah, so we basically with the vascular, that is the blood vessel, look at the blood vessels and conditions that can happen in them that can take place. So, of course, one of the things that we need to realize in every system that we are going to discuss, you have to go back to your anatomy, look at it again, because once you get a good understanding of anatomy, then it becomes easier for you to understand the conditions. So here, of course, you can see even the first slide there that we have a medium-sized muscular artery. So we want to look at the artery, the anatomy. Basically, you're looking at the histology. You're looking at the microscopic anatomy of the blood vessel. So you're looking at the wall, the blood vessel wall. Yeah, so when you look at the wall, you're seeing that is a normal blood vessel. You'll have the endothelium. Endothelium basically is the inner lining of blood vessels, be it arteries, be it veins, is the inner lining. And so in this case, we are having we are having the endothelium being the epithelium, the inner lining of the blood vessel. And then the second layer, we have the subendothelium. You will see in some places they're talking about the lamina propria. That is the subendothelium, the lamina propria, tunica. So those two up to the internal elastic lamina. So internal elastic lamina, the subendothelium and endothelium, that is what will form the tunica intima. That's what will form the tunica intima. The endothelium, that is the epithelium of the blood vessel. Then you have the subendothelium, that is the lamina propria. Then we have the internal elastic lamina. So those three will form the tunica intima. And then when you look at next layer would be the tunica media. And when you talk about the muscular artery, it means the tunica media, which consists of smooth muscle, will be a bit large. You see, most of these vessels, the differences will be the sizes of the various layers. So tunica intima, that is tunica media, is where the smooth muscles will be. And I know we talked about the smooth muscles last time when we were doing anatomy 1 and even in anatomy 2. Then you have an external elastic lamina. And then after that, we have the tunica adventitia. And you realize that tunica adventitia, especially for the large vessels, is where we have the vasa vasorum. In the large vessels like the aorta, you will have a vessels that supplies that particular vessel. We call it vasa vasorum. And you can see in that tunica adventitia, you can see a blood vessels being shown there. And so it's important that we really get this clearly, because for most of the things we'll talk about, it will be easier if you understand the anatomy, the histology of the wall of the blood vessel. And then again, we moving to the second slide, atherosclerosis. Remember this one we have talked about in pathology 2, and it's very important because the vessel problems and then that affect will have something to do with atherosclerosis. So it's the most common pathological abnormality of the arterial tree. So there is thickening and hardening walls, and the hypertension, diabetes, others. So I really encourage you to go back and look at it, because I think we did in some details already done the vital signs, the blood pressure, and I know all of you should know the more normal the normal range for hypertension, for the blood pressures. So, of course, when you talk of hypertension, you're talking about elevated blood pressure. So, usually these elevated blood pressures, especially if they are not well controlled, of which all of us in the medical profession, one of the things that we need to encourage our patients is that they be able to control. If they are hypertensive, they should be able to control the blood pressure using medication. Because when it is well controlled, then they just are as normal as they will be as any other normal person. Yeah, but of course, when they're not well controlled, then they affect the blood vessels, especially the small blood vessels. That is what we call arteriolosclerosis. When you look at atherosclerosis, you're talking of hardening of blood vessel walls. And most of the time, of course, you talk of atherosclerosis, and we know the process because we did that in last time in some detail, and I really want to encourage you to go back and read it again. And you look at the first one there, hyaline arteriolosclerosis. There is hyaline material that is accumulating within the tunica intima and partly in the tunica media. And of course, the effect that has is narrowing of the lumen. Yeah, and when you look at the next, which is hyperplastic arteriolosclerosis, we know hyperplasia, which is increase in cell number. We talked about it in pathology 1 about hyperplasia, which is increase in cell number. So you can see there is in the smooth muscle in the tunica media, there is proliferation, that is increase in number of smooth muscle cells. Yeah, in fact, we have hyperplastic arteriolosclerosis. Of course, the effect, just like the first one, would be to narrow the lumen, the vessel lumen. And then we have necrotizing arteriolitis, that is inflammation. Yeah. So necrotizing has to do with necrosis. And I think we did about the different types of necrosis. And when there is necrosis of vessel or any other tissue, you can see there is the polymorphonuclear lymphocytes. That is like neutrophils and so on, because there is inflammation. And so you have those polymorphonuclear lymphocytes there. And of course, there is still also proliferation of the smooth muscle cell in the tunica intima. And so just like the others, the effect will be to reduce the lumen. And so the blood vessels moving to the area that is supplied by those vessels will reduce because the vessel lumens are going to reduce in size. And of course, hypertension, that is high blood pressure, will affect all the organs in the body. It will affect everywhere where there are blood vessels. So wherever blood vessels are, if you have elevated blood pressure or hypertension or high blood pressure, it will affect vessels wherever they are. So any organ will be affected. The heart, the kidney, the liver, name any organ, even the lower limbs, they will all be affected if you have hypertension that is not well controlled. And so when you look at that vessel there, that is a micrograph. That is basically a picture of looking under the microscope. That is after preparation, staining. Probably you should be able to tell me probably which type of stain was used here. Most of the time is H&E that we use. And you can see the vessel when you look at the one on the left. Of course, this is cut. The one that is on the left cut is transversely. It's that to the transverse cut through that vessel. And then you can see the tunica intima, maybe not very visible. And you can see the lumen is markedly narrowed. You can see the tunica intima, IN there. Then you can see tunica, you can see the tunica intima, IN, and then you can see the epithelia, the media, tunica media. And then we have internal elastic lamina. The E that you see there is the internal elastic lamina. So we have the tunica intima, internal elastic lamina. Then we have a hyaline, that pinkish stained substance. That is the hyaline. And you can see all that is causing the blood vessel lumen to be narrowed. And then in the picture on the right, you can see the hyaline. You can see that small blood vessels. There's a lot of hyaline in its wall and causing it to narrow. And this is in the kidney. Yeah, if you see the micrograph on your right, That is how the kidney tubules will appear. And so the effect it will have, of course, if you think of it, is that finally it will cause problem with filtration in the kidney. The function of the kidney will be affected. And finally, if it is not well controlled, you end up with kidney failure or renal failure. And when you talk about essential hypertension, basically what we mean there is that the hypertension can either be essential, can also be called primary. Usually the cause is unknown. But when you talk about secondary hypertension, that means there is a specific known cause that is causing the high blood pressure. Mostly more than 90% of the hypertension that we talk about would be essential. That is, you cannot find a cause. So all you can do is just to treat it and to control it. That is essential hypertension. So moving on, the type of hypertension I've already mentioned a bit. We talk of essential hypertension, which is, as I said, the cause is unknown. You can call it idiopathic, or you can call it primary hypertension. All those mean the same thing. Essential hypertension, idiopathic hypertension, no, primary hypertension mean the same thing. The cause is unknown. When you talk of idiopathic, it's something basically you will see in many conditions. When you talk of idiopathic, basically you don't know the cause. We usually jokingly say that in this case, where somebody has a problem and nobody knows the cause, they say the doctor is an idiot, or the nurse for that matter, and then the patient is pathetic, as in you can imagine a scenario where you're sick and you're in hospital and nobody can find the problem that is ailing you. You probably will be quite pathetic, and in that case, the doctor will be idiotic. But that's on a light note. And of course, the other cause, the other type of hypertension that we have is secondary. That is, you know the cause. And there are not many, just like 5% of the hypertension have a specific cause. Most of them will be essential hypertension. So most of the patients that you will see with high blood pressure in the ward, they will have essential, idiopathic, or primary hypertension. Then for larger arteries associated with arterial dissection. So larger arteries, for example, the aorta, the ascending aorta, the aortic arc, maybe even descending aorta. Usually there is what we call dissection. For example, thoracic aorta. So dissecting, as it is to cut. So you find that there is a defect within the tunica intima in the blood vessel, those big blood vessels. And so when you have a defect in the tunica intima, the effect will be the blood will be able to seep through into the tunica media. That is where the smooth muscles will be found. And so it will dissect. Dissect basically is to separate into two. So that's what we mean by dissection. So for the larger arteries, there is an association with this hypertension that is not controlled. If you don't control it well, then you are likely to have what we call arterial dissection, quite common in the thoracic aorta. And usually this one can cause sudden death. Yeah, I remember when I was in medical school, there was somebody who died of sudden death. When they did the postmortem, they found that there was a massive thoracic aorta dissection. There was basically a blood clot inside the wall of the aorta that was separating that tunica intima into two, basically. So that's what we mean by dissection. Yeah, so some of the causes, or when you talk about pathogenesis, as in what is causing that dissection, so one of them could be medial myxoid. Myxoid refers to jelly-like substance. So it could be the medial, that is the tunica media, can degenerate in a way that is forming gel-like substance. So degeneration, destruction of the medial tunica media. Or it could be cystic medial necrosis. That is, cyst basically refers to something that is fluid-filled. So there is degeneration, fluid accumulate in the tunica media, and there is necrosis, that is death of cells. And so you have that dissection, you have that separation. And mostly it occurs in adults in any age. It can occur in adults of any age, but most common in the middle age. So I don't know what most of us would call middle age, maybe 50, 60. I don't know what middle age would be. So it's more common in that age, but generally in adults, it's rare in children. And then when you look at the number between females and males and females, it's most common in males. In fact, the patient that I was talking about those years was male. So most of them would be male. Yeah, the female is rare, but it still can happen in any gender. Yeah, so of course it's very important that we really get to understand hypertension because we are always managing it. I believe one of the vital signs that you guys have been taught how to do is to measure blood pressure. And that is one of the vital signs that we talk about, blood pressure. And so hypertension is very important and we had better really get good understanding of it. Hypertension and how what can cause it and how even to prevent it and how to manage it. So when you look at the smaller muscular arteries, they would be in their walls. There will be progressive thickening of their walls where we have symmetrical. So what causes this to thicken, the walls to thicken, is that there is symmetrical hypertrophy of the muscular media. So hypertrophy, as we had said, is increase in cell number. So those smooth muscles within the tunica media increases in size. And so that is one of the things that will cause the wall to thicken in the small muscular arteries. And then there is also extensive reduplication of the internal elastic lamina. You remember back, you have to think about that anatomy that we talked about. Remember, there is the endothelium, then next is internal elastic lamina. So when we talk of reduplication, basically it increases, like it becomes two layers. So there is the internal elastic lamina, then there is another one. So you see, like, it's duplication. Duplicate is like reduplicate, it has to increase. Maybe it was one becomes two, three, or more. So it's extensive reduplication of internal elastic lamina. And then what happens again, there is fibrotic thickening of the intima. So whenever any inflammation, of course, this is one of the things that will happen during this scenario is that there will be a bit of inflammation at any one time. And one of the things that happen in inflammation is that there is fibrosis. So there is that fibrotic thickening of the intima. That is tunica intima. And so all this will lead to reduced diameter of the lumen. And so you can imagine there was a blood vessel, that vessel was taking blood to a specific organ, then the amount of blood that is reaching that organ will definitely be reduced. Yes, so then when you talk of arterioles, so it's good to remember the blood vessels. You go all the way into arterioles, you have capillaries, you have to remember again those blood vessels, go revise them again and just know them through. So when you look at the arterioles, there is, of course, as we have already talked, there is hyaline arteriolosclerosis, which results in wall thickening. There is reduction in size of arteriolar lumen, that is the lumen of the arterioles reduce. Then in the kidneys, as we've already mentioned, that if you have these arterioles that are going to the kidney are reduced in size and so on, so you end up with compromised renal blood supply with chronic ischemic damage of the glomerulus. We call it hypertensive nephrosclerosis. So basically, we'll be looking at the kidney also later on with the things that can happen in the kidney. So and we already know what is ischemia. So basically, ischemia is reduced blood supply. Yeah, as opposed to necrosis, infarction. If you have completely cut blood supply, then you end up with infarction. That is basically the death of. Yeah, and of course, glomerulus. One of the things that we look at is glomerulus is basically in the kidney, is blood vessels, a collection of blood vessels where ultrafiltration takes place. We call it a glomerulus. Yeah, and so when those vessels are narrowed, you are likely to end up with compromised renal blood supply. And so when you have that, finally you will end up having compromised renal function. And of course, if it is not controlled or it is not reversed, then you may progressively end up with chronic kidney injury and maybe finally renal failure or kidney failure. Then we have what we call accelerated hypertension. Yeah, or you can also call it also known as malignant hypertension. So you can call it accelerated hypertension or malignant hypertension, as opposed to the other hypertension that is not malignant or accelerated. So in this case, the increase in blood pressure is of rapid onset to a marked degree. So the increase in blood pressure is very fast, is very rapid. and to a marked degree. So here we are talking about the systolic blood pressure. Remember, there is systolic and then there is diastolic blood pressure of more than 220. You remember the very normal blood pressure we talk about, which rarely anybody attains, around 120/60. That is the systolic is 120, and then the diastolic is around 60. You can see here the blood pressure goes over 220 millimeters of mercury. And then the diastolic pressure, 120, more than 120 millimeters of mercury. That is very high and it is rapid. So muscular arteries develop severe thickening of the tunica intima and proliferation of intimal cells. So here we have those muscular arteries developing severe thickening of the tunica intima. That is why I tell you we needed to start with anatomy, because if you are going to understand, then you have really got to gather anatomy quite well. And that's what they are calling in quotes onion skin appearance. That means basically you have layers. You know how the onion is. You see, if you are to peel the onion, there are layers. It is layered. Mostly, of course, we are talking about the onion that is, I don't know what you call it, the rounded one. I think that is the one that is we mostly have. You see, if you cut it, you see there are layers. So the tunica intimal will appear like it is layered. That is what we're talking about, onion skin appearance. Yeah, still on accelerated hypertension. So in moderate hypertension, that is the hypertension that is not so severe, that is not accelerated, what we call moderate hypertension. The tunica media and internal elastic lamina remains largely unchanged. So tunica media, internal elastic lamina remain largely unchanged in moderate hypertension. Then arterial, still in accelerated hypertension, intimal cells undergo rapid proliferation. So intimal cells in proliferation, that is basically increase in number rapidly. And then there is the disruption of vessel wall. So the wall is disrupted, that is basically destroyed. Maybe there can even be destruction. There are some perforation through the wall, and so they end up being leakage of plasma proteins into and beyond the arteriolar wall. That's what we call fibroid necrosis. And I think we did last time, where you can go back always and revise. As I told you, for your course and medicine and all, it's basically building on what you already know. So you cannot say you cannot go back to what you needed to build on that. So if you didn't get and understand well the previous classes we had last year, then it will be difficult. So it will be advisable to go back and revise again. So in this case, the lumen is often completely occluded. Then damage to the vessel wall may lead to thrombosis within the lumen. I think we talked about thrombosis, and we know some of the causes that can cause thrombosis, and basically a clot occurring within the blood vessels. As we have said before, in normal situations, a clot should not form in a normal blood vessels. Usually a clot will form outside the body, but not within the blood vessel. But of course, there are cases when we talked about thrombosis last time. So go back and look at it. So when there is, of course, thrombosis within the vessel, then it will block the vessels. Then we move on to aneurysm. Aneurysm. We're still looking at blood vessels. So these are abnormal dilatations of the heart or blood vessels. So it's not just the blood vessel, even the heart. Yeah. So within the chambers of the heart, if the dilatation, it can occur within the heart and it can occur within the blood vessels. It is most often encountered in relation to the aorta, so it's more common in the aorta. Remember, the aorta, you have the ascending aorta, the arc of the aorta, the descending aorta, the thoracic aorta, then you can have in the abdominal aorta. So this aneurysm is most common in the aorta, and also is found in the ventricular wall of the heart. That is the wall of the ventricles. Remember, in the heart, there is right ventricle, left ventricle, then we have the atria. So in the wall of the ventricles, it is also encountered. These aneurysms will be there. And as we say, it is dilatation of the heart or blood vessels. So they just dilate. It's like ballooning. So ventricular wall of the heart or vessels of the base of the brain. I believe all of us still remember about the circle of Willis. When we talked about the blood supply to the brain, we talked about the circle of Willis. And at the base of the brain, remember those blood vessels that eventually supply the brain. So around that base of the brain, is so aneurysms are common. Then we have type of aneurysm. So we have aortic aneurysm that is basically affecting the aorta. Most common etiology, when you talk about etiology, we talk about a cause. When you talk of etiology, you're talking about a cause. And of course, you will find in some book, the etiology, they will start with an A, then E, especially the British English, but the American English, mostly they use the E, they leave out the A, so etiology. So the most common etiology that is for aortic aneurysm is as a consequence of atherosclerosis. And that is why I told you to really go back and look at atherosclerosis. It's something that should still be part of pathology 2, but we already did it in pathology 1. So go back and look at it. So most of the causes for aortic aneurysm would be atherosclerosis. The vessel wall becomes thin as a consequence of medial distraction. So the intima, the tunica intima is the one that is usually destroyed, in the aortic aneurysm. Some of the complications of aneurysm. So you can imagine if a vessel is dilated, it's just like the way you blow a balloon. And the more, of course, if you blow it, the bigger it becomes, the weaker it becomes. That if you are to touch that balloon with just something sharp slightly, it will probably just burst. So you can imagine if the vessels are ballooning or the ventricles are ballooning, and so they're becoming thinned. So some of the complication is it can lead to hemorrhage. So it can rupture and bleed. Yeah. That aneurysm also, what will happen is if you have, as we said, one of the predisposition to development of thrombus was if there is no laminar flow, that is the vessel is not smooth. Yeah, so if a vessel has a dilatation at some point, then it will slow down the blood or there will be turbulence. And that in itself will predispose to the formation of thrombus. So there will likely to be thrombus formation leading to occlusive or embolic phenomena. So occlusive, if you develop a thrombus, it's likely to block the vessel completely. Secondly, that thrombus can be dislodged, and then you end up with embolism. Basically, an embolus, which we talked about in last term, where now this emboli will move, and when it reaches a smaller vessel, then it will block. So those are some of the complications. Of course, among others, these are not the only complications. And then we have the types of aneurysms. You come atherosclerotic, that is caused by atherosclerosis. That is, as we had said, for example, more commonly in the aorta, but atherosclerosis can affect any vessel. Then we have circular, when we can also call them berry aneurysm. You'll hear in some book about berry aneurysm. It means the same thing. And this one mostly will be found in the cerebral circulation. You know, the circle of Willis that we talk about at the base of the brain. So this is more common there. This circular or berry aneurysm will be found mostly there. And they manifest, that is, we're still talking about the berry aneurysm or circular aneurysm. They manifest in middle age, and they're often multiple, that is more than one. There'll be several of them at the base of the brain. Then we have what we call microaneurysm. Basically, these are very small aneurysm, maybe in very small vessels, but they're still aneurysms all the same. So micro, very small. Then mycotic, when you talk of mycotic aneurysm, you talk of infective. So there is infection of bacteria to the blood vessels or something that causes it to become weak. And so you end up with an aneurysm, and we call it mycotic or infective aneurysm. Then syphilis. Thankfully, in the current times in which we live, syphilis should be rare. Of course, syphilis, is a sexually transmitted infection, which thankfully is rare. One of the things that we used to, a blood test that that is used to test for syphilis, we call it VDRL. I don't know whether you probably will be able to learn it as you move to the wards. It's called VDRL. It's a test. It's a blood test that we use to check for syphilis. Thankfully, syphilis have become rare, but it's still there. For syphilis, one of the things that it does is it destroys part of the wall of the blood vessels, and so you end up with aneurysm, which we call in that case syphilitic aneurysm. And of course, there is a picture there of diagram showing the different types of aneurysm. Yeah. So when you look at the first one, circular, you realize it's just one part of the berry aneurysm that we are talking about. When you look at it, it's just one part of the wall that is weak and that is ballooned, just one side. Yeah, that is circular aneurysm. Fusiform, as you can see, the fusiform is uniformly dilated in a smooth way. Yeah, so that's what we call fusiform. Then cylindrical, it almost looks like a cylinder. So for some reason, there is that weakness, not fusiform, but it's cylindrical. Then serpentine, you can see small dilatation in a vessel. Yeah, so someone was talking like a serpent. When you talk of a serpent, you talk of a snake. So serpentine. And then when racemose, you're thinking about, they look like a cluster of grapes. That is, you need to think about grapes. So there are many, they look like a cluster. So it's called racemose. So those are just some of the type. Then we have major sites. And then you can see that diagram, that is the aorta. You can see the ascending aorta. So just around the ascending aorta, the more common one that tends to affect there is in a person who has syphilis, that disease is likely to affect the ascending aorta. So you're likely to have the syphilitic aneurysm in the ascending aorta and part of the arc of the aorta. And when you come down there towards within the arc of the aorta and the descending aorta, dissecting aneurysm is quite common. And we talk about dissection. Basically, we say there will be a defect within the tunica intima, and blood is allowed to seep in through into the tunica media and causing it separation. That's what we call dissecting. So it's more common at the arc of the aorta and even the descending aorta. That's the thoracic aorta, dissecting aneurysm. Syphilitic aneurysm we talked about. And then mycotic, that is infective, is more common in the descending or the thoracic aorta. And then atherosclerosis thereafter in the abdominal aorta, in those vessels that go to the various organs like to the kidney and so on, then you are likely to find more of atherosclerotic aneurysm. And then you see the circle of Willis, that is the base of the skull, where we talked about berry aneurysm, the circular aneurysm, the berry aneurysm. And we said there are multiple, so at the base of the brain, or those blood vessels that are supplying the brain. And then, of course, we have a picture there just showing the dissection of the aorta, whereby you're looking at, you can see the tunica intima, IN, then you can see the media, and then you can see the hemorrhage. That is basically a clot, hematoma. That is a hematoma. That red, that indicated H, that is a hematoma. And you can see it's dividing almost like 2/3 of the medial part of the tunica media and the external part, maybe just a third. So you see where it's located. So it's basically dividing it. Yeah, and that is what we mean by saying dissection. So in this case, it's the aorta. There is dissection of the aorta. The blood vessel was able, the blood supply. So probably the defect in the tunica intima is higher up. So the blood is able to seep through and form a hematoma there or a hemorrhage and divides. So that now you have the wall has been divided into two. Part of it involves just a small part of the tunica media and tunica adventitia. Then the rest is most of the tunica media and tunica intima. Yeah, so that is the dissection of the aorta. And then again, just dissecting aneurysm, looking at the end at the most common places, you can see there the heart and the ascending aorta. And we are told that there is a defect or there is a tear within the intima, tunica intima, and that allows blood to get into tunica media and goes through, dissect it or divide it. And you can see that dissecting aneurysm. You can see the adventitia. So there'll be that division that most of around 2/3 of the more internal part of the tunica media and part of so the upper part will mostly be just a part of tunica media and tunica adventitia. And then you can see the dissection can involve can go through the entire aorta. And then, of course, you can see on the diagram on the right, you can see the dissection that we are told about the interior inner two-thirds of the tunica media. Then we have the outer third. And then in between now is where the tunica media is being dissected. So that is where the clot will flow through. And then you can see the lumen. And of course, the lower diagram basically is a picture of the heart, a specimen of the heart. And you can see those arrows are basically pointing to a clot within the walls of the aorta, the blood vessels wall. So that is dissection. And then, of course, you can have inflammation of blood vessels. And I think we talked about even how to just give names to inflammation. So basically, we'll call it vasculitis. Yeah, the inflammation of the blood vessels, vasculitis. And you can have all, I will not go into a lot of details in this. Arteries, if it is arteries, you can talk of arteritis, capillaries, capillaritis, you can talk of veins, you can talk of phlebitis, but you can still call it venulitis. Of course, they can be caused by many things, including inflammation, it can be infection. Yeah, inflammation is not necessarily infection, it can be caused by many things. And so we have classification of these inflammations where you can have direct infection. For example, syphilis can affect the aorta, and so you end up with what we call syphilitic aortitis. You can also have aspergillus infection. I suppose you'll be able to look at this infection in another subject, probably microbiology or whatever. I'm sure you'll be able to know what kind of infection that one is. Then you can have damage to vessels, for example, by mechanical trauma and radiation injury. Of course, there can be a lot of injuries, including maybe during surgeries. For those of us who do surgeries, you can injure those vessels. And so when you traumatize the vessel, you end up with inflammation. Also, radiation injury, for example, in X-rays. That is why we don't encourage people just to do X-ray, CT scan anyhow, because they can actually cause injuries to the blood vessels, and then we end up with inflammation. It can also be immunological. Those immune reactions, antibody, antigen reactions can cause inflammation. Of course, it can be idiopathic. Basically, the pathogenesis is unknown. Those are inflammations. Then we can have malformations and tumors of blood vessels. So blood vessels, you can still have malformations. You can have tumors. For example, when you talk of hemangioma, hematomas, these are basically developmental abnormalities, and most of the time they will be benign. So you can go ahead and look some more. And go look at what hematomas. I'm sure if you check Google, you'll be able to find out. So initially they are benign. Then we have what we call arteriovenous malformation. So as you can see from the name, the arteries and the vein-based malformation. And usually the brain is an important site of this arteriovenous malformation. So whereby you have an abnormal connection between the arteries and veins. And usually you end up with, it can end up actually causing there to be an aneurysm or something else. Then glomus tumor, called it also glomangioma, which is a benign tumor. Then we have Kaposi's sarcoma, can call it KS. It's an etiological agent. The etiological agent is human herpes virus 8. Yeah, HH8. There are many variants of human herpes virus. And that is one of the things that causes Kaposi's sarcoma. And actually, Kaposi's sarcoma, when HIV started in the 80s, I think, when it came to knowledge, it was one of the, what we call AIDS-defining disease. So that because people had not known what HIV, people were just getting sick, they had never understood. People would come with all sorts of complications of HIV, immunosuppression. So many people who are immunosuppressed, especially HIV or any other immunosuppression, people who are undergoing maybe after kidney transplant, usually they have to be given immunosuppressives, and they're likely to develop Kaposi's sarcoma. And usually it can affect the skin, it can affect the esophagus, it can affect anywhere in the body. Then we have what we call angiosarcoma. When you see something about angio, it refers to blood vessels, and usually most frequently in the skin, soft tissues, and it can occur also in the breast or the liver. So we move on. So those were mainly vessels. Of course, we have talked about the heart as well, but we want to look at the heart. And as I said, we need to always start with the anatomy, because once we understand the anatomy of the heart properly, then it is easier for you to understand the conditions that affect the heart. Of course, when you look at that anatomy, just to remind ourselves of the anatomy of the heart, which I hope you already still remember, you can see the inferior vena cava, superior vena cava, that will bring the oxygenated blood, the superior vena cava from the upper part of the body, the inferior vena cava from the lower part of the body to the right atrium. So it will bring blood to the right atrium. From the right atrium, we have the right atrioventricular valve. And we said valves basically are things that allows blood just to move in one direction. In this case, blood will move from the right atrium to the right ventricle. And so the valve that we have there is right atrioventricular valve, or we can call it tricuspid valve. That it has 3 cups. That's what we can call tricuspid valve. So blood will get from there into the right ventricle. And you can see in the right ventricle, you can see the chordae tendineae that is connecting the valve to those papillary muscles, basically a projection from the muscles of the heart. We have what we call papillary muscles. So you have those chordae tendineae. And so you get the blood gets into the right ventricle. And then, of course, in the right ventricle and generally in the heart, you can see the myocardium. And you can see always the left ventricle, the muscle should be bigger, because we know from the left ventricle, the blood should be pushed further all over the body. And so usually the myocardium of the left ventricle tend to be bigger as compared to the right ventricle. Because mainly at the right ventricle, you're pushing blood to the lungs. And so from the right ventricle, you see the heart will contract during the systole, and it will push blood into the pulmonary trunk. And through there, you have the pulmonary valves. Yeah, that will allow blood to move into the pulmonary trunk in one direction. And so it will move through the left pulmonary artery. That blood will be taken to the left lung. And then through the right pulmonary arteries, the blood will be taken, the deoxygenated blood will be taken to the left lung, to the right lung. So, of course, the blood will be oxygenated and come back into the heart through the pulmonary veins. You can see the left pulmonary veins, that is from the left lung. And then we have the right pulmonary veins from the right pulmonary vein from the right lung. And then it will come back now into the left atrium. And then from the left atrium, the blood will move to the left ventricle through the left atrioventricular valve, what we call it mitral valve. Mitral valve. And then you can see also the chordae tendineae, you can see the papillary muscle that connect the valve to those muscles and maintain it. And so once blood, of course, is in the left ventricle, during systole, the blood is pushed through the aortic valve into the ascending aorta. And we know that after those valves, usually there are those coronary arteries that come out from there to supply the muscle of the heart. We know of coronary arteries, which we talked last time and said that they are considered as functional end arteries. I hope you still remember about end arteries, where we had functional end arteries, and then we have anatomical end arteries. So usually coronary arteries are considered as functional end arteries. And so usually the coronary artery will come off the ascending aorta just after the aortic valves to supply the heart. And so in short, will be the anatomy of the heart, which is very important. You must be able to understand it. If you're going to understand the condition that we're going to look at, then you must be able to understand, remember, revise again the anatomy of the heart, including the histology. So when we go to the next, we're looking at the histology. You're trying to look at the heart microscopic anatomy. And you can see the heart there is being cut. And then you can see the pericardium, basically the outside part of the heart. The pericardium, I hope you know about the pericardium. Then there is myocardium, that is the muscle of the heart. Then the endocardium basically is the inner lining of the heart, call it endocardium. And you can see a cut is made there and then expanded there. Then you can see down there, you have the myocardium, that is the muscle, the heart muscle. And then inside part, we have the endocardium. Yeah, that is the inner lining of the heart, the inside part of the heart, the endocardium. And then, of course, you can see the intercalated disc. I think we talked last time I think it was anatomy 1, about the heart muscle or cardiac muscle. It's a special kind of muscle, which is voluntary among others. Then you can see the nucleus, you can see the branching of myocardial cells. And then, of course, you can see, more importantly there, you can see between the pericardium and the heart, there is the pericardial space with pericardial fluid. And that fluid, so it's usually a potential space, very little fluid, just to help the two surfaces to move smoothly. As the heart is contracting, it should move smoothly between the heart and the pericardium. And you can see the pericardium. Of course, we know there will be visceral pericardium, then we have the parietal pericardium. And in the pericardium itself, we have the parietal pericardium, and then we have the fibrous pericardium. So that is very important because you can have fluid accumulating excessively within the pericardial space, and though you end up with pericardial tamponade, that is basically causing pressure on the heart and affecting its contractility. Of course, any of this can be affected. The muscle of the heart can be affected, for example, myocardial infarction, where for some reason blood supply, the coronary arteries are affected, and so you end up with myocardial infarction, and you may end up with heart failure. Basically, myocardial infarction, you're talking of a heart attack. So moving on to ischemic heart disease. So having looked at the anatomy and hopefully understood the gross anatomy and even the histology, then you can easily understand all these other, the ischemic heart disease. Basically, you're talking of ischemia. So for whatever reason, blood supply is cut from getting to the cardiac muscle. Yeah, so ischemia or reduced. The blood supply to the heart muscle is reduced. That is basically either the coronary arteries are narrowed or something blocks them. So in almost all cases, the cause is atherosclerosis of the coronary arteries with or without accompanying thrombosis. So most of them are caused by atherosclerosis, which, as I said, go back and revise, and that I will still be, it will be something that I'll have to set exam on because it's important. So most of the time will be caused by atherosclerosis of the coronary arteries with or without accompanying thrombus. So, of course, when you have atherosclerosis, one of the reasons that can cause risk of formation of thrombus, and this thrombus, of course, being a clot, can block the coronary arteries. So, myocardial infarction, commonly sometimes we just say MI, that is basically heart attack, is a common consequence of coronary artery disease. So, coronary arteries either are narrowed or they develop atherosclerosis, hardening and narrowing, and so on. And it's a leading cause of morbidity and mortality. When you talk of morbidity, you're talking about disease, illness. Yeah, basically you talk of morbidity, and then mortality is death, especially in developed countries, but not necessarily so, because even in Kenya, it's becoming quite common because all of us are becoming urbanized, so to say, as in we now live in town, a sedentary lifestyle. We're using cars, we're using boda, we are quite sedentary. We are not active, we are not walking. So basically those diseases are not anymore just developed countries. It's now in our country as well, especially in urban areas. It's becoming common. So it's a leading cause of morbidity and mortality in developed countries. So some of the symptoms, any disease that we will be studying, you need to think about the symptoms and signs. So as signs and symptoms. Symptoms is what the patient will complain about, and signs is what, as a clinician or a doctor, a nurse, you will be able to, from examining, you're able to get and say these are the signs. So one of the things that in myocardial infarction, the patient will come with central chest pain. So pain right in the center of the chest. which may radiate or moves. And you talk of something radiating is starting there but moves to the left arm or even to the left jaw. So that is the kind of pain the patient will come with. They say, I feel pain in my chest, and that seems to be moving to the left arm or even to the jaw. And then there may be nausea. That is feeling like, yeah, nausea. I don't know what you, then nausea, you can even have vomiting, breathlessness. So they may have difficulty in breathing because you remember now, if there's myocardial infarction, the pumping of blood is not as well. So oxygenation of blood is not as good. So you end up with breathlessness. They may be sweating, among other signs and symptoms. So, how do you diagnose myocardial infarction? Of course, from the history, you are able to get what the patient is complaining about, and then you are supposed, of course, to examine. And when you are examining the cardiovascular system, always you start with, of course, you have to measure the blood pressure. Usually, the pressure is likely to be low, they're likely to be hypotensive. You're supposed also to check the pulse. Their pulse is likely to be very fast and so on because they tend to have tachycardia, the heart trying to compensate. Yeah, and of course you can do lab tests. You take some blood tests, and usually when you do that blood test, there will be elevated levels of proteins from damaged myocytes. That is muscle cells. The cardiac muscle cells, myocytes, are destroyed, and there is one we call cardiac troponin and myocardial creatinine kinase. So you look at the blood test, and this one will be elevated, will be very high, because there is destruction of myocytes. That is the cells of the cardiac muscle, and they release these particular proteins. And of course, how do you treat the myocardial infarction? It's very important that we have a high index of suspicion, so to say. And so the way to treat it as much as possible is really to try and establish a reperfusion of the ischemic segment. Yeah, so you're trying to reperfusion. Basically, if the blood vessel was blocked, the coronary artery, you want to remove whatever is blocking it. And I think we talked about the various things, including thrombolysis. Thrombolysis, you can use some drugs that are supposed to lysis or break down the clot. And I know in pharmacology, I don't know whether you've done it or you will at least do it, you'll be told about these drugs. Like, for example, there's a very common drug we use in the world, rivaroxaban. We use for patients who are not ambulant, who are on traction, for example, to prevent clots from forming. So this is one of the things that you can do. Of course, you can do surgery, which we mentioned last time. You try to remove whatever it is that is blocking the vessels and so on. Or if the vessel is blocked, you try to do bypass surgery. Yeah, you use graft to bypass whatever the block is to try and regain the reperfusion. So, of course, we can have many complications, which could include sudden death. It's a common, as we have said, cause of mortality, cause of death, and even morbidity. So, most of the time, if you have a patient who has sudden death or somebody dying from suddenly, most of the time it has to do with cardiovascular issues. Yeah, most of the time it is cardiovascular. Sudden death, that is somebody even doesn't reach to hospital, they just die suddenly. Most of the time it's cardiovascular in nature. That is either involving the heart most of the time. So it can lead to sudden death. It can lead to arrhythmia. You know, rhythm, when you talk about rhythm is supposed to be sinus rhythm. The normal rhythm in the heart should be, we call it sinus rhythm. So when you talk of arrhythmias, it's not having any rhythm at all. And so when you have arrhythmias, then the contraction of the heart is affected. And so blood is not pumped as it should to the rest of the body. And so this in itself can lead even to death, arrhythmia. Of course, myocardial infarction, if you injure the heart muscle, you destroy it, finally the contraction of that heart will be affected. So you can end up with cardiac failure, or you can call it heart failure. Yeah. And I think when you rotate in medical ward, you'll find a lot of cardiac failure or heart failure in patients, and there's a way of treating them. You can imagine if there's heart failure or cardiac failure, there will be a backflow of blood into the lungs, and so you end up with pulmonary edema and so on. You end up with edema of the limbs. You end up with maybe pitting edema and pitting edema because there's a lot of accumulation of blood backflow backward. And then you can have, of course, because the muscle is affected, the myocardium is affected, you can have a rupture of the ventricles. So you can have ventricular rupture. The ventricle can rupture. Yeah. You can also have rupture of papillary muscle. Remember the papillary muscle, those are the muscles that hold and maintain the valves. Yeah, if you look back at that anatomy, we have the papillary muscles. So those muscles, if they're affected, then we have failure of the valve. So we'll have acute valve failure. You can have mural thrombosis with potential for thromboembolism. Basically, when you talk of mural, that is basically that is forming within the tunica intima, that is the endocardium. Yeah, because the muscles are affected, there'll be some inflammation there. So you'll have a thrombus forming. And that thrombus can easily embolize. That is, can detach and be taken away. So you can imagine if there is a thrombus within the left ventricle, it will be able to move into the ascending aorta, and it can get anywhere. It can go into the brain and cause stroke. It can go into the kidneys and cause kidney failure. It can go to the limbs and even cause limb ischemia. If it is in the right ventricle, it can move and cause blockage within the lungs. It can cause pulmonary infarction. So there is that potential of thromboembolization. Yeah. So when we talk about cardiomyopathy is basically you're talking about abnormal myocardial function without an obvious etiology. So in this case, it will be more of idiopathic, so to speak, as in nobody really knows the cause. You will just find a problem. The function of the heart is affected, yet you cannot get an obvious cause. And usually these abnormalities, these cardiomyopathies, in plural you call it cardiomyopathies, that is myopathies, put there HIES, cardiomyopathy. So these abnormalities usually cause progressive cardiac failure. So they tend to cause progressive cardiac failure. And of course, one of the things, if somebody has a cardiac failure, maybe as I've already said, one of the things that will happen, there may be generalized edema all over the body. There may be difficulty in breathing because there is some backlog of fluid into the lungs, so they end up with pulmonary edema. Somebody is likely to have easy fatigability, as in somebody who has a heart failure can hardly walk fast. Whenever they walk, they become tired very easily. So we call it easy fatigability. They cannot climb stairs. When they climb stairs, they start breathing so hard, as in there is that easy, they become fatigued very easily. Yeah. Of course, another thing that you're likely to have in scenario of cardiac failure or heart failure is palpitations. Somebody, when you talk of palpitation, you're talking about awareness of heartbeat. Somebody, usually you shouldn't be aware of your heart beating in normal scenario, unless when you are anxious, scared, or you have a problem, you are sick. Then you are likely to be aware of that. That's what we call palpitation, awareness of heartbeat. And then, of course, when you do the blood pressure measurement, BP is likely to be low, and so on. And when you look at the precordium is the chest region that is just slightly above or directly above where the heart will be. We call it precordium. Usually, sometime in some heart failure, you're likely to have that area, that precordium becoming hyperactive. You see, it is moving so fast, it is hyperactive. And of course, this is where now you use your auscultation, your stethoscope. When you auscultate, then you are likely to hear some abnormal sounds or murmurs, we call them. So those are the things that you will look at and maybe say this person probably have a cardiac failure. So when you have cardiomyopathy, you're likely to develop progressive cardiac failure. And then we have classifications of these cardiomyopathies. You can call it dilated or congestive cardiomyopathy. So basically here is just like the heart is just dilating, just ballooning out, called dilated or congestive cardiomyopathy. Then we have hypertrophic, we can call it obstructive cardiomyopathy. We have restrictive cardiomyopathy. And then you can see there just diagram attempting to show the same. So that when you look at the first one is the normal heart, where you have the pericardium, you have the myocardium, you have endocardium, the inside part of the heart, that is the basically the epithelium of the heart. So when you're talking about dilated cardiomyopathy, you can see there the lumina, that is the ventricles, right atrium, left atrium, left ventricle, right ventricle, they are all dilated. The lumina are dilated. And then the endocardium is thickened. So the inner part, remember the heart, there is endocardium, there is myocardium, and then there is the visceral pericardium. So in this case, you have the endocardium becoming thickened. When you look at, they may be those thrombus, mural thrombus we've already talked about. You can easily develop those thrombus there. So that is dilated cardiomyopathy. And then we have hypertrophic cardiomyopathy. The lumens are narrowed. You can see obliterated lumina. The lumens are becoming narrow because there is asymmetrically thickened myocardium. So the myocardium is thickened, and then the septum is basically the division that divides the ventricles. So it becomes hypertrophied as well. So usually you will find this, but as we have said, we can't be able to know exactly. In most cases, we can't find the cause. So you just find the heart is thickened, the myocardium is thickened, the septum is hypertrophied, and then the lumina or the lumen are narrowed or obliterated. So that is hypertrophic cardiomyopathy. And you know, hypertrophy is basically increase in cell size, as we had already talked, and as we talked in the last same. Then when we have restrictive cardiomyopathy, in this case, you see that the mural endocardium is markedly thickened. And then you see the myocardium is thinned. So basically restrictive cardiomyopathy. So the heart is not able to dilate. When blood comes in, it's not able to expand as it should because that endocardium is markedly thickened. So it's restrictive. Yeah, so I believe you can be able to see and hopefully. So make sure you go read around all these and helps you understand. That's why usually I put a lot of diagram because anatomy really and all this, it helps, even to understand. And I hope for those of you who went to the lab, hopefully you are able to see some of these pathologies. And because usually the reason you go to the lab, the reason you go to the wards, it helps with memory because once you see something, then it becomes easier to remember and even understand. So that's why I encourage you guys. Very important not to miss. Hello. So please mute whoever mute while I'm gonna. So we'll continue. We have the congenital anomalies of the heart. We have congenital anomalies of the heart. Just like every other system, one of the things that we need to think when you think of any system or any organ, you want to think of the diseases that cause it. Could be congenital, it could be inflammatory in nature, it could be tumors, that is maybe cancers and so on, or malignancies. It could be infectious. So that is how you think about an anomaly in any organ. It could be infectious, it could be metabolic, it could be iatrogenic. When you talk of iatrogenic, you're talking of doctor caused or nurse caused or whoever caused by whoever the person who is trying to help that person. Then it could be also traumatic, that is trauma. Because any organ can be traumatized, including even the heart. And it can be traumatized really in injuries in road traffic accident. You can injure even the heart or any vessels. So trauma is another thing. And then it could be vascular. When you talk of vascular, you're talking of blood vessels, basically, which we've already talked about, and it can still be. And you can you realize when you talk about cardiovascular, most of the diseases we are talking about is vascular in nature. So, of course, and we talked about, we did embryology. And I don't know, you'll need to go back and probably remind yourself about embryology. We talked about, I remember we had a class on fetal circulation. Yeah, and we talked about once the baby is born or the fetus is born, what happens. this opening, like the ductus arteriosus, is usually supposed to close. But if it fails to close, then we have what we call patent ductus arteriosus. Yeah. And then, of course, there is a septal defect, which usually should close just before birth or after, immediately after birth. And so if it doesn't close, you end up with what we call atrial septal defect. So there is a connection between the two atria, the right atrium and the left atrium, and you can be sure some blood now will not be moving properly to the lung. Some of it will go without being oxygenated to the other side and into the systemic circulation. So then there will be problem with oxygenation of blood because there is that. Likewise with patent ductus arteriosus, there will be mixture of oxygenated blood with deoxygenated blood. So some of the blood will move to the systemic circulation without being properly oxidized or oxygenated. And then we have coaptation of the aorta. Basically, you're talking of the aorta narrowed, congenitally. That is basically the narrowing of the aorta. So that's coaptation of the aorta. There's something we call Fallot's tetralogy or Fallot's tetralogy. When you talk of tetra, you're talking of four. So there are four anomalies there. There is stenosis of the pulmonary artery. So pulmonary artery is stenosed or narrowed at its point of origin. Just at the origin, as it leaves the heart, it is narrowed there. So we call it stenosis of the pulmonary artery as one of the tetralogy. Then the second one would be ventricular septal defect. So there's a defect between the ventricles. Between the left ventricle and the right ventricle, there's a defect there. Yeah, ventricular septal defect. Remember the septum that is separating the two sides of the heart. So if there is a defect there in the ventricle, we call it ventricular septal defect. The third one is aortic misplacement. So the aorta is misplaced, is basically displaced. And then we have the right ventricular hypertrophy to counteract the pulmonary stenosis. Yeah, so because there is that stenosis of the pulmonary artery, the right side of the heart will tend to become hypertrophied to try and counteract it. So we have the Fallot's tetralogy: stenosis of pulmonary artery, ventricular septal defect, aortic misplacement or displacement, and then right ventricular hypertrophy. And then, of course, we have those pictures there showing, you can see the coaptation of the aorta, basically narrowing of the aorta there. You can see the right ventricle, left ventricle, pulmonary trunk. And of course, from the aorta, there you can see blood now going back, and then it will tend to narrow there. So I know you can imagine if it's narrow, what is likely to happen? If you are to measure the blood vessel, the blood pressure at the leg, and then the blood pressure at the upper limb in the scenario of coaptation of the aorta, what do you think will be? And I don't know whether somebody can answer. In this coaptation of the aorta, if you are told to do a blood pressure at the leg and do a blood pressure at the upper limb, what are likely to be the differences between the two? Anyway, so I'll just answer anyway. So you are likely to have a low blood pressure if you are to measure it at the leg as compared to if you are to measure it at the upper limb. Because basically there is that narrowing, so not much blood goes down to the descending aorta. Most of it, so there'll be a lot of pressure of blood going to the upper limbs and even to the head. Of course, it's not safe. It's likely to cause problem, especially in the brain, because there is a lot of pressure that is likely to go there. And this is one can possibly cause hypertension actually in the upper part of the body. Yeah, this is one of the secondary hypertension can be a coarctation. Aortic coarctation could be one of the causes of hypertension, secondary cause of hypertension. Majority of them, as we are saying, causes of hypertension are idiopathic or essential. That means the causes are known. We have the tetralogy of Fallot or tetralogy of Fallot. And then you can see all those. There is the ventricular septal defect. You can see the defect there's an opening between the left ventricle and right ventricle. As you see, even some blood, of course, some deoxygenated blood will move directly from the right ventricle into the left ventricle. And then you can see right ventricular hypertrophy. That is, the right ventricle is, if you to compare, usually the left ventricle should be bigger than the right ventricle. That is, if you want to look at the myocardium on the left ventricle and the right ventricle, the left ventricle should be bigger because we know that's the one that will push blood all over the body. But in this case, you can see actually the right one is becoming bigger than the left. And so you can see there'll be mixing of blood, the oxygenated blood going through to the left ventricle through the ventricular septal defect. And then you can see the pulmonary stenosis. Just after the start of the pulmonary trunk, there is a narrowing there. And so there will be a lot of pressure. It's narrowing. So the blood will still go to the pulmonary trunk, but it will require a lot of pressure for it to go. And that is why the right ventricle become hypertrophied. And so some blood will move through the septal defect to the other side, to the left ventricle, and goes to the systemic circulation without proper oxygenation. Yeah, and then you can see the aorta will be slightly displaced because the aorta will tend to move towards that ventricular septum. It will just stay up above, just above the ventricular septum. So it tends to become misplaced or displaced there. So you see those four: the right ventricular hypertrophy, the ventricular septal defect, the pulmonary stenosis, and the aortic displacement, the tetralogy of Fallot. Patent ductus arteriosus. Yeah, you see where the arteriosus is PDA, patent ductus. Patent refers to open. Usually it should close. Usually it is there, and I believe you have to go back and revise the embryology, which we talked about, the fetal circulation, which we had already talked about. Usually these ductus arteriosus should close upon delivery. But if it fails to close, you can see where a situation. So blood will move from the right ventricle through the pulmonary trunk, and it will move to the left and right lung. But you can see as it goes to the, for example, the left side of the left lung, for instance, in this case. So once it comes from the right ventricle, remember blood in the left ventricle will be under higher pressure. So it will go through the ascending aorta and it will go through the aortic arc. So what will happen is, because the blood that is coming from the aorta has a lot of pressure and there is an opening in the patent ductus arteriosus, and the blood flowing to the lungs usually will be at a lower pressure. So it means some blood from the left, from the aorta, the arc of the aorta will get into the pulmonary trunk. And so there is likelihood to be there a lot of blood overloading in the lungs, because some blood will get there from the aorta and join the blood that is going to the lungs. And so you are likely to have a lot of blood overload within the pulmonary vessels. So that is the patent ductus arteriosus. Of course, one way of treating it is usually cardiothoracic surgeons, that is the surgeons who deal with vessels and the heart and the lungs. They do surgery, they open the heart. They usually don't open the heart itself, they open the chest and be able to locate this particular defect, and you're able to tie it with a suture to tie it and close it. Close it tight, just basically tight and close it. So that is how you do that surgery. You're able to correct that patent ductus arteriosus. Then we have the atrial septal defect. You can see basically there's something, so you should be able, from your fetal circulation, you should be able to go revise and know what was there in the fetal. In the fetus, that septal defect should be there. Yeah, but usually upon delivery, it should be able to close. But in this case, if it doesn't close, it probably would mean that some blood will be coming out from the left atrium to the right atrium. And so there is likelihood of there being an overload also in the lungs because of that defect. Then ventricular septal defect. So you can have just ventricular septal defect. You can just have defect in the between the two septa, the left ventricle and right ventricle. And so, as we said, because there would probably be high pressure in the left ventricle, some blood will get back to the right ventricle, and there's likely to be an overload within the lungs. So ventricular septal defect. So those are some of the malformation, congenital anomalies that can be found in the heart. So inflammation of the heart. So when you think about the heart, of course, you have to think about all the layers. Pericardium, you can have pericarditis. And mostly this one is caused by viral infection. And then, of course, myocardium, you know, the muscle of the heart, you can have myocarditis, also mainly viral infection. Then you can have endocarditis, that is basically the inflammation of the inner layer of the heart, endocardium. And mostly this one will be mostly bacterial or fungal infection, so endocarditis. Then you have valvulitis, which could be bacterial or fungal. These are the valves. So we have inflammation of the valves, which could be caused by bacteria or could be fungal. Cause of pericarditis, this can be caused, it's not just infection alone, it could also be caused by myocardial infarction, because when the heart is infected, it will also affect this pericardium. Remember the pericardium, there is a visceral pericardium that is firmly attached to the heart. Then there is the parietal pericardium. It can also be caused during cardiac surgery, because usually when you do cardiac surgery, you have to open the pericardium so that you're able to access the heart. So that in itself can cause inflammation and cause pericarditis. Viral infection, that we've already said, malignancies, although malignancies in the heart usually is rare, but it can be there. Also uremia. Uremia is in a scenario where there is renal failure. There is an elevated level of urea within blood. And this in itself can cause pericarditis, can cause the pericardium to become inflamed. Bacterial infections can cause pericarditis. And then rheumatic fever, which we'll look at shortly, the rheumatic fever is another thing that can cause pericarditis. So primary myocarditis, that is inflammation of the heart, can be associated with viral infection, can be associated with rheumatic fever, and exposure to certain toxins and drugs. Or it could just be also idiopathic, that is, you cannot know the cause, just happen and you can't find a cause. And then there is endocarditis and valvulitis. Endocarditis, inflammation of the endocardium, that is the inner lining of the heart, inside the heart chambers. That is basically the endocardium, the epithelium of the heart. And valvulitis, that is inflammation of the valves. Know all those valves that are there. Involve not only inflammation, but also thrombus deposition. So it's not just inflammation. Usually there is also thrombus deposition. There is formation of thrombus on the endocardium and or valves. So in most of these endocarditis and valvulitis, usually it's associated with thrombus deposition on the endocardium and also the valves. And of course, you know the risks. The likelihood of there being an embolus that is likely to go block organs distally that are supplied by the blood. And then the symptoms of myocarditis, just like we had said, for every disease, you need to know about the symptoms. That is, what complaints will the patient come with. So in this case, the patient is likely to come with chest pain, tachycardia. That is, tachycardia is elevated blood pulse rate. That is, they'll have tachycardia. The pulse rate will be very high. And of course, this is one of the vital signs that we always do, pulse rate. So there will be tachycardia. Or the heart, if you were to auscultate, the heart will be beating very fast. Yeah, the rate of, there will be high. Arrhythmia, that is the rhythmic contraction of the heart will be affected. So there will be what we call arrhythmia. They're likely to have fever. They're likely to have fever, that is high temperatures. And this is likely to lead also to cardiac failure. So somebody will come with features of cardiac failure, edema, difficulty in breathing, and so on. Usually would have taken place several weeks earlier. So if you were to ask a patient, do they have a sore throat? They will probably tell you maybe 1 month ago, I had a sore throat, or the child had a sore throat, had a throat infection, but it resolved. So systemic manifestation present a disordered immunological response resulting in inflammation of connective tissue. So it can affect any connective tissue wherever it is in the body. And it shows a disordered immunological response. So usually what people think is this bacteria, when it affects the throat, it produces, of course, we talked about antibodies, that if you have this antigen, in this case, the streptococcus, antigen, the body will produce antibodies against it. They usually say that those antibodies that are formed start attacking or cells that look similar to those cells in the throat, and one of those is usually the heart muscles, and so on. And so it will. That's why they are talking of disordered immunological response. Just like we talked about autoimmune, where the body forms antibodies against self tissues, as in self. You produce antibodies are now attacking cells that belongs to that person. Yeah, so basically that is what also rheumatic fever is thought to be. That is a disordered immunological response resulting in inflammation of connective tissue. All parts of the body may be involved. So it can involve the joints, it can involve the skin, it can involve, it can be with painful short-term consequences. So in fact, one of the things when you talk of rheumatic fever, when you read a medical book, they talk about especially rheumatic heart disease. There is a criteria that you use to say this is rheumatic fever. Because one of the things, once somebody is discovered to have rheumatic fever, they're usually supposed to be injected some antibiotics over a long time, like 3 weeks. Some of them even almost for very long, up to they're like 16 years or even more. I can't remember the criteria, but there is one of the criteria is polyarthritis, as in there's joints pain in many joints, among others. These are the criteria. If you go read about rheumatic heart disease, you'll be able to find a criteria of how to say, now this is rheumatic fever. But I see, of course, out there in the huko mashambani, sometimes they just, there's a test called ASOT. And the streptococcus, which they use, call it ASOT, which is a blood test, but it's not accurate, because I've seen many people who are being put on medication just because that test was done and it was positive, which should not be the case. It's a criterion in which you have to say somebody has a disease and then treat accordingly. So there is involvement of the heart causes. So it can involve the heart. Just as we said, it can involve many organs. Yeah. Involvement of the heart causes acute myocarditis and endocarditis, and the long-term consequences of chronic scarring of the heart valves. One of the long-term is scarring of the heart valves. Myocardium and endocarditis, which this endocarditis will affect even the valves. And so you will finally, just like we talked about the healing, we know the healing process. One of them is scarring. Yeah, we talked about a second intention, which you should be able to think out it, revise again. So once you have this inflammation in the valves and even in the heart, once the healing takes place, it's likely to take place with scarring. And so you have scarring of these heart valves. And of course, when they become scarred, they're not able to close and open as it should. So you end up with valves problem. Like you can have stenosis of the valves. You can have these valves becoming incompetent, that is regurgitation, because of the scarring. Then we have rheumatic carditis. There's a lesion called Ascoff body, which is central ill-defined area of degenerative material surrounded by a mixed inflammatory cell infiltrate rich in T lymphocytes. That is rheumatic carditis. Involvement of the heart valves, as we've already talked about, endocardial roughening induces formation of fibrin and platelet thrombi. So basically, when you affect the valves, that the endocardium become roughened, and so it becomes one of the risk factors for developing thrombus. Yeah, so likely to develop platelet thrombi, and of course with the attendant risk of embolism taking place. Then chronic rheumatic valvular disease is the result of organization and fibrosis. Can affect any valve, mitral valve, tricuspid valve, and the left tricuspid valve, the tricuspid valve can affect any valve, the aortic valve, the pulmonary valve. So as I said already, that scarring and affect those valves. They make them either incompetent, that is, it's not closing properly and allows blood to flow back. That is what we call regurgitation. Or you can have stenosis. So you are likely to see something like mitral stenosis, aortic valve stenosis, or you can have mitral valve regurgitation. Any valve can either be incompetent, that is, it allows blood to flow back, or it can become stenose. Of course, when it becomes stenose, it becomes narrowed, and so the heart will have to pump. You are likely to start developing hypertension because the heart will have to pump strongly to be able to pass through the stenosed valves. This continues over many years with eventual thickening and distortion of the valve leaflet as well as chordae tendineae. So all those end up being distorted. Side distortion commonly renders affected valves stenotic or incompetent. So when you talk of stamming stenosis, that is narrow and incompetent, it is not closing as well, so it allows blood to flow back. So during systole, the blood should be able to be pumped, for example, into the aorta, ascending aorta. But now when the heart pumps during systole, blood will go into the ascending aorta, for example, but once the valve closed, because it's not able to close completely, blood goes back. We call it regurgitation. So that's what we mean by incompetent. The valves become incompetent. There's a diagram there and a micrograph showing rheumatic heart disease. You can see there a fibrin plate thrombus. There's a thrombus forming. You can see that valve. So there's a thrombus forming there. There is congestion. There is inflammation there. And so a thrombus is forming there within the valve. You can see the mitral valve there. That is in the left ventricle, left atrium. You can see the valve. Because of inflammation, a thrombus is forming on it. And then, of course, under the microscope, not very clear, you can see mononuclear cells there. Yeah, so basically that is a rheumatic heart disease, looking at it histologically. Valvulitis. Yeah, basically that is endocarditis of the valves. That is valves. Endocarditis of the valve is what we call valvulitis. So the primary phenomenon underlying all these conditions is the formation of thrombus on the valve leaflets or caps. So you end up developing a thrombus because those become roughened and so on, and so a thrombus form there. The roughening of the endocardial surface predisposed to thrombus formation, previously damaged by rheumatic fever, congenitally abnormal. So it could be that roughening of endocardial surface predisposed to thrombus formation because basically you could have a vessel that previously damaged by rheumatic fever, or they could be congenitally abnormal, or could have autoimmune valve damage. For example, in systemic lupus erythematosus. Systemic SLE, systemic lupus erythematosus is an autoimmune disease which can affect all parts of the body, including the liver, the kidneys, and so on. So there is one endocarditis we call marantic endocarditis, which is a most frequent type of valve thrombus. So it causes a thrombus, a most common type of valve thrombus. There is a warty thrombotic vegetations develop on mitral and aortic valve. So this one mainly affects the mitral valve. That is the valve that's from the left atrium to the left ventricle, and the aortic valve. So it affects mostly. And warty, I'm sure we've seen, probably most of us have seen a wart. So basically saying it looks like that, and then it has thrombosis. And when you talk of vegetation, you're talking of basically thrombus that has been infected. So that's what we call vegetations. So they develop on the mitral and aortic valve. So, and this one mostly will occur in people who are seriously ill, patients who are seriously ill, or patients who could be, even in this case, would be people with widely disseminated malignancy. That is basically they're having a cancer that is widespread. And these are patients who are likely to develop this marantic endocarditis. And this one is associated also with hypercoagulable states. That is, this one is from the body is likely to form thrombus, hypercoagulable state. So risk of formation of clots, thrombus, usually not a feature valve at the time of there was no inflammation at that point. And it could also be involved with infective endocarditis. We have thrombotic vegetation on valves. So you have thrombus that is infected, the vas will become infected with bacteria, or other organism. That's what we call infective endocarditis. Thrombus, those vegetations become infected. And you can see infective endocarditis there. The mitral valve, you can see the left atrium, ventricle, the valve there with congestion, necrotic tissue, bacterial colonies. So basically infective, that is, the thrombus has become infected. We are calling it infective endocarditis. Yeah, and of course, it's an inflammation, lymphomonuclear, lymphocytic neutrophils, those are that will come. Basically, an inflammation, which you already about, and you can see from that micrograph on the right. That is now a micrograph that is looking under the microscope state and all, and then you can see all those there, including you can have all those fibrinous chronic inflammatory cells, and so on. Bacterial endocarditis, virulence. So when you talk of subarachnoiditis, can be subacute. This one is when there is colonization of low virulence. That means basically of bacteria of low virulence is if there's some bacteria, if you have only 3 bacteria in the body, think of the number, you become sick. But there's some of bacteria when you need to have like 100 of them for you to become sick. So the one that you talk of them having a low virulence. Yes. So subacute is colonization by bacteria of low virulence. So that such bacteria you will have to have a lot for you to get sickness. So when you talk of acute, infected by virulent organism, that is such as Staphylococcus aureus. So this one you just need a small number of bacteria to cause problem, to cause illness. So when you talk of acute bacterial endocarditis, it means you are infected by virulent organisms. When you talk of subacute bacterial endocarditis, the body or the person is colonized by bacteria of low virulence. Then we can also have fungal endocarditis. Remember, fungus can cause infection. Yeah, just like bacteria, just like virus, just like parasites. Those are some of the things that can cause problem, infection. So you can also have fungal endocarditis. But this one, it used to be quite rare. Yeah, but it's a complication of immunosuppressive therapy. Like as I said, somebody who had a transplant, kidney transplant, for whatever reason, usually they will be, these people will be immunosuppressed. Yeah, and so such people are likely to develop fungal endocarditis. So otherwise, for normal people who have normal immunity, they are unlikely to develop fungal endocarditis. Of course, you can be sure also in people commonly use cocaine, or people who inject themselves drugs like cocaine, or that is basically so people who are addicted to these drugs, and people who have HIV, AIDS, because they are immunosuppressed, likely to develop fungal endocarditis. So when you look at the common type of fungi that cause fungal endocarditis, the most common one is what we call Candida albicans. I'm sure you'll be able to look at it when you do microbiology. When you look, there's a common fungus called albicans. Usually the most common. Readily detached, leading to major embolic consequences such as cerebral, renal, or splenic infarction. So you can be sure if it comes out and it's on the left ventricle, it will go all the way to the cerebellum. That is going through the blood vessel that goes to the brain and can cause infarction there and even stroke. It can go down the descending aorta into the abdominal aorta, goes into the renal arteries and goes into the kidneys and block and cause infarction in the kidney. So it can affect the kidneys. Also, it can go into the spleen, yeah, and block it and cause problem with the spleen. And then any organ you can think about, including the lower limbs. Then primary tumors of the heart. Yeah, usually these ones, thankfully, they are very rare. And even when they are there, majority will be benign. Yeah, majority will be benign. So they are there, yes. Tumors can affect any part of the body, any organ. You can have a tumor, and tumor can either be benign or malignant. So when you talk of tumors, most of the time we are referring to cancers, we are referring to masses, we are referring to neoplasia. There's what we call myxomas, most common benign tumor in adults, called atrial myxoma. So most of the time will be found in the atrium. That is why it's called atrial myxoma. So this is basically a mass, yeah, within the heart, usually rare. So if you're talking about signs and symptoms, it will be non-specific. When you talk of non-specific symptoms or signs, that means they'll have some symptoms that will be common to many other conditions. So it will not be specific to this disease. You'll have like flu-like symptoms, like homa, for example, outflow obstruction. So of course, it's likely to block. If it is in the right ventricle, it's likely to block blood from flowing properly to the aorta, for example. So it's likely to cause blockage to the outflow of blood. So outflow obstruction. Of course, it's likely to develop, it's likely to cause thrombus to form. And so they are likely to cause embolism. Yeah, which is in this case usually most common. Even itself, that mass sometimes part of it can detach and become an embolus. And of course can cause embolic phenomena. Macroscopically, when you talk of something macroscopically, is basically under the gross, that is under the naked eye, that you can see with the naked eye. These myxomas will be pedunculated, variably soft to firm masses, often arising in the region of the atrial septum. So it tends to arise from the region of the atrial septum. That is, we have to look at it macroscopically. That is how it will be. Then histologically, that is microscopically, there will be some stellate tumor cells. Stellate will almost be like star-like tumor cells and abnormal vascular channels set in myxoid matrix.